Hello, everyone. Welcome. My name is Jennifer Behrenpral, and I'm the project manager for South-Southwest Mental Health Technology Transfer Center. For those folks who may be listening instead of watching our webinar, I'm wearing a burgundy shirt. I have shoulder-length brown hair, got a bright yellow background, and I have a big smile on my face because I'm really happy to be here with you today. My pronouns are she and her. I am very honored to be your host for today's conference panel, which is the State Peer Support Best Practices panel. I want to thank all of our wonderful panelists. We have a really wonderful group of people for you to hear from today, as well as our outstanding moderator. And also just a big thanks to you all for joining us. We had a great start, great kickoff to the conference with Pat Deegan, and this is going to be just as phenomenal. And we really hope that you find today's presentation helpful. This presentation was prepared for the MHTTC network under a cooperative agreement with the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. The opinions expressed in the presentations are the views of our panelists and don't reflect the official position of the Department of Health and Services or SAMHSA. All right. Well, let's go ahead and get started. I would like to take this time to introduce a really special person. We have a really very lucky to have an excellent moderator with us today. Lieutenant Commander Tracy Murray has been a registered nurse for over 10 years with experience in clinical research, epidemiology, and nursing education. She earned her Bachelor of Science in Nursing degrees with honors from Texas Christian University. Soon after, she became the first BSN to PhD graduate at the University of Texas at Tyler. Lieutenant Commander Murray recently completed her Master's in Public Health with a global health emphasis at University of North Texas Science Center. In 2017, Lieutenant Commander Murray became a commissioned nurse officer in the U.S. Public Health Service and began her service with the Indian Health Service. She currently serves as the Region 6 Assistant Regional Administrator for the Substance Abuse and Mental Health Services Administration in Dallas. As a commissioned officer, Lieutenant Commander Murray is active in the Black Commissioned Officers Advisory Group and Commissioned Officers Association. Really happy to have you here. So at that, Tracy, I am going to pass this off to you, and thank you all for being here.
Great. Good afternoon to everyone. Thank you for joining our panel discussion. And for the next 90 minutes, you'll hear from some amazing innovators in peer support and learn about their work and leadership in the field. You can read their full bios on the event website, but I'll briefly introduce each of them in order by state. And as I introduce them, you'll see their video turn on. For Arkansas, Jimmy McGill overcame incarceration and 23 years of addiction and now serves as the recovery manager for the Arkansas State Drug Director's Office. He holds multiple peer recovery certifications and has trained over 300 peer recovery support specialists. He also developed the Peers Achieving Collaborative Treatment Program and the Arkansas model of peer recovery, which has gained national attention. For Louisiana, we have Ricardo Williams, who is the Peer Services and Consumer Affairs Coordinator for the Louisiana Department of Health's Office of Behavioral Health. With over 11 years of experience in mental health, he also brings a strong criminal justice background with a bachelor's in criminal justice and master's in criminal investigation from Southern University. Representing New Mexico, we have Militia Montana, a woman in long-term recovery, and she serves as the program manager for New Mexico's Office of Peer Recovery and Engagement. She is a certified peer support worker and trainer and has 2 endorsements on her CPSW, Certified Support Housing Peer Specialist and Certified Older Adult Peer Specialist. Her current focus is a cross-agency collaboration for a unified peer support model in New Mexico. We also have Rachel Sosi, who has 3 years of recovery and is a certified peer support worker with LifeLink Training Institute in Santa Fe, New Mexico. Representing Oklahoma, we have Tony Stelter, who is also a person in recovery and serves as Director of Recovery Supports for the Oklahoma Department of Mental Health and Substance Abuse Services. He is a certified peer recovery support specialist and licensed professional counselor. He is also a founding member of the Lived Experience Advisory Committee for the Suicide Prevention Resource Center. Also representing Oklahoma is Lindy Siebel. She's a citizen of Cherokee Nation and works in opioid overdose prevention with the Southern Plains Tribal Health Board. She's the project coordinator and co-facilitator for the Indian Country Peer Recovery Support Tele-ECHO program. She earned her Bachelor's of Art in Native American Studies at the University of Oklahoma and is a certified peer recovery support specialist. Last but not least, I saved the best state for last, my home state of Texas. And representing Texas is Noah Abdinor, who is a certified mental health peer specialist and the Director of Peer and Recovery Services Programs, Planning, and Policy at the Texas Health and Human Services Commission. He led the advocacy effort to create a peer support Medicaid benefit, Texas House Bill 1486. And he is considered a subject matter expert on recovery-oriented care, peer specialist integration, and peer-centered care. So now that you know a bit about our distinguished panelists, let's jump right into the discussion with our first question. So what is a highlight of peer services for your state or tribe? Really something you're proud of, a best practice, or a major achievement. And to start us off, we'll start with Arkansas. Jimmy?
Thank you, Lieutenant. I think Arkansas's newest initiative is something that we're very proud of. It is funded through the Co-op 2 grant, which is the Comprehensive Opioid Abuse Site-Based Program. It's a Bureau of Justice grant. What it did was allowed our state to launch 6 strategically placed initiatives pairing law enforcement investigators with peer recovery workers. And so basically you've got a dynamic duel. You've got one coming at overdoses from a law enforcement side, and then you've got the peer support worker advocating for treatment instead of criminal justice systems. And so we've got a team of 6. We've got 6 different teams. And I'll just give you an example. One of our peer recovery specialists that is working currently, he's covering 5 counties. In the last 3.5 months, Josh has been on call to 35 different overdoses. 20 of those people, instead of being incarcerated, Josh is currently right now transporting his 20th person to treatment. And so that's pretty amazing. Another one county peer, Joseph, and they've given me permission to talk about them today. And so Joseph has been on 11 overdose calls. He's got 8 of those people into treatment. 5 of them are currently living in long-term IOP, thriving. And so because of peer support work, these people were detoured from criminal justice jails and prison sentences to getting the treatment that they deserved and that they need. And so we hope to see more of this blossom across our state as we go on. But as far as best practices go, Lieutenant, I believe the thing that we're really thriving on in Arkansas is our peer recovery workforce is supervised only by peer support workers.
Awesome. Thank you so much for that. Ricardo, would you like to go next and share thoughts from Louisiana?
Sure. So a couple of highlights from Louisiana. Just this past March, we implemented peer services as a Medicaid reimbursable service. This is something that we started about 2 years ago. And so that journey itself has been an uphill battle, but we were able to implement it in March. Whenever we implemented it, we opened it up to a limited number of providers. So that allows us to be able to monitor it a little more closely, identify some tracking and monitoring mechanisms that we can put in place to make sure that that the program continues to grow and also is used appropriately. Another thing that we did prior to the start of the pandemic, we were training. I think we trained in about up to 60 peers per year with our peer trainings. We had only 4 trainings per year. During the pandemic, it allowed us to implement a virtual training. And so with that virtual training, in 2020, we trained 83 peer support specialists, virtual trainings. And so this year we are on track to train over 100. And so that will both include virtual and in-person. We haven't started our in-person trainings back up yet. We have a class that will be in person in July. And so with that class, along with other classes that we have planned for the remainder of the year, we'll be well over 100 peers trained for this year. Another program that we're getting ready to kick into high gear is My Choice Louisiana program. And so with that program, we utilize peer support specialists, or we call them peer in-reach specialists. And what that program does, it assists individuals within nursing homes. It gives them the option or the choice to get back into the community, be able to provide for themselves, live independently within a community. And so those peer support specialists work with those individuals within the nursing homes, give them a voice, show them the options that they have to living outside of that nursing home independently. And so there's a program that we're just starting to really kick into gear. With that program, we will have peer support specialists within each of the 10 regions to help with within their respective region.
Great, thank you. And I see some participant comments coming in with some way to go, some wows and some awesome. So thank you all for what you're sharing. And I'd like to turn now to New Mexico. And Militia, would you like to start us off with New Mexico?
Yes, ma'am. Thank you. Thank you, Lieutenant. And can I just say what an honor it is to be sitting on a panel like with my peers, especially from our Region 6 family. Every state here is just the leaders. I mean, Jimmy McGill has said it before. We have walked, out of the fires with buckets of water to help our peers and make, train our peers to do the same for their communities. So sitting here is something I get to do. And because of the folks on this region, I am a better person. But one of the biggest highlights that, comes to heart for me right away is this project that we started before, right after COVID hit. And we named it the Hallmark Project. And it was one of our deputy directors at BHSD. She called it that because at the beginning it was called the Displaced Project. And what we were doing was we had been sent home, right? And we're home and we're wondering as peer support workers, what can we do to help our fellows now in this craziness? So Dr. Bowen, he got on board with his staff, and we started an initiative called the Hallmark Project, where we trained some peer support workers in New Mexico to do some telephone peer support and to help support the warm line and the peer-to-peer warm line and the New Mexico Crisis and Access line. And some of these folks were in motels, and lo and behold, in 4 months that we started this project, we served about 483 people. But we did a warm handoff to LLTI and Lifelink Training Institute, and Rochelle can talk about that later. But that was just like almost 500 people in 4 months. Now I know it's in the thousands, and so it includes so much more, just so much more than it was peer support in motel rooms to families. we reached the rural parts of New Mexico with this project. And it just, I said to myself, at the end of this whole pandemic, can we have a summit so we can meet the people that were on the other side of the line? Because we, instilling hope into someone and being scared at a motel was really amazing. And then the resources that we're able to follow through there. And that's just one of the things. And I'll just really quickly go by that. We also, like Ricardo mentioned, we also went digital. We are on our 17th training from March of 2020 in New Mexico. Now at the end of this month, every month, we have a digital training. We have trained over 300 people in 1 year. And that, as crazy as that sounds, it's the fact that peers are resilient and that we got together as a team and that we made that happen and we rolled it out. And with with leadership behind us, we were able to do that. We also have, we've also incorporated a couple of live Facebook feeds where we can focus on an agency and then also focus on a peer that week. And talking about resources, we're also collaborating with the National Latino Behavioral Health Association, and they do what they do is they have a segment called Platicas at noon when everybody's having lunch, and you can sit back and listen to a conversation with a peer, an agency, our faith-based folks that are out there helping peers right now, people coming out of the prisons. We also, we're very, very excited and talking about best practices. Miss Deegan that we listened to earlier, we in New Mexico, we instill that hope in our peers. And can I say how proud I am of the peers that are out in the, on the front lines doing the work. Yes, we're here at Opry, we're doing the admin, we're getting the ball rolling for them, we're doing the trainings, we're facilitating those, but it's the peers in New Mexico that are on boots on the ground. Rochelle will tell you about that. And I'm sure in every other state too, man, the work that we do is from the heart. It's, compassion and action. And shout out to every peer in the US or wherever else you are, that we are able to do this and that we're getting through this in a pandemic.
Great, thank you for that. And Rochelle, your name was mentioned so many times, so I'm sure you have some things to add here. So I'll turn it over to you, Rochelle, for additional comments on work being done in New Mexico.
Hi, everybody. So real quickly, I'm going to introduce myself. Yat e shikedo shidene nisha odone nishliningi she Rochelle Sosi Inishia. Toda chitni nishle to bahen bashichi, Kenya ani dashiche she and dashinala. Akot ego nishle, te hozane de nasha, Shama e Rosita Emerson, Wolia, Shija e Ronald Sosi Wolia. So I just said, hello, my people, my friends, my family. My name is Rachel Sosi, and I introduced myself as Bitterwater, the Edge of Water, the Towering House and Salt People Clan. In that way, I introduced myself as a young woman originally from Winter Rock, Arizona. My parents are Rosita and Ronald Sosi. And I am very glad to be here today. Thank you everyone for having me. So I'm sorry, I'm a little off here. What was the question?
I just wanted to know if there were additional highlights you might have from your work in New Mexico through LifeLink Training Institute and the partnerships that you have with Militia and work being done.
Okay, so in the middle of that, my little boy had woken up, but I apologize, everyone. I do work with the LifeLink Training Institute in Santa Fe, New Mexico. We are funded by FEMA and certified by Opry. So what we do with the LifeLink Training Institute as peer support workers is, so far we've been working with people in the beginning of COVID-19 is where we really had to step our game up and make sure that we're reaching out not to those that were in recovery, but also to those who had like mental health illnesses, depression really kicked in, domestic violence, you name it. It was all there. Our job was to pick up that phone and let them know that we're here as certified peer support workers because of lived experience. And then we would provide these individuals with tablets, with phones, any resources that they may need, getting their social security cards, birth certificates, IDs, trying to get them out to like Alcoholics Anonymous, Narcotics Anonymous, depression support groups. Some mothers needed support groups because, you know, they're locked up in a hotel with their kids. They're going crazy, you know, and this was a new thing for all of us. So we would help them through that. And then when we would help them with getting iPads, we'll do this like face to face so they could see who they're talking to. A lot of them had difficulty with just hearing our voice. And we realized it's important that they see and our facial expressions. That really helped a lot. So we also started to collaborate with the WEC Center in Albuquerque, the Westside Emergency Housing Center. We sent some of our peers over there, boots on the ground, and also same thing, provide them with resources that they needed. And oh, and don't let me forget housing. We help them out with housing. There's a lot of homelessness, a lot of mothers on the streets with addictions and with their kids. We would work with their case managers and we would get them into housing, get them vouchers, a lot of stuff like that. So, and we really love what we do.
Great. It sounds like it. Thank you so much for sharing. And now we'll switch over to Oklahoma. So Tony, would you like to start and add some comments from Oklahoma on some of your highlights, best practices, or major achievements?
Yeah, I'd love to. Thanks, Tracy. I too, like Militia, I want to say how honored I am to be on this panel with such awesome people. So Oklahoma has, I think we have a lot of best practices that I'd love to talk about, but what I want to highlight today is the use of certified peer recovery support specialists and warm handoffs between levels of care within our the Department of Mental Health and Substance Abuse Services behavioral healthcare system. As most of you probably know, certified peer recovery support specialists excel in engagement and targeted outreach as well as follow-up. That's kind of our sweet spot. So in the past, consumers would leave crisis centers, they'd leave inpatient or residential substance use, and they get a referral, you know, and then they'd kind of fall in the gap, fall between the cracks sometimes. And a lot of times that would lead to relapse of mental health symptoms, possibly substance use. For those with a history of suicide risk, as many of you know, this is a real critical time immediately following discharge, and those with that risk are 300 times, have a 300 times higher risk of suicide than the general population. So building that connection and make sure that connection happens and that gap is closed is super important. So what we started doing here in Oklahoma many years ago is we started employing and deploying peer recovery support specialists to help with that connection, help close that gap. We use peers at the higher level, hired through that higher level care through inpatients and crisis centers to follow up with folks when they're leaving, engage with folks while they're there. But what's also happening is on the outpatient level, at the lower levels of care, peer recovery support specialists are entering into the inpatient treatment and into the crisis centers, in the residential substance use centers, and they're engaging folks right from the very, very beginning. They're part of their discharge plan, they're part of their treatment team, they're building that connection and that relationship so that person has that connection when they leave immediately to go to that next level of care. In fiscal year 2020, I'm going to throw some stats at you because I feel like that helps put things into perspective. But in fiscal year 2020, those discharging from inpatient or crisis care, 83% of those folks had follow-up within 7 days. 78% did not readmit to inpatient or crisis services within 6 months, and 81% were engaged in treatment within 45 days. I think that's amazing, and that shows like the great work that the peers, certified peers in Oklahoma are doing. I also want to mention and shout out, we have some awesome recovery community organizations in Oklahoma that are also bringing that non-traditional support, behavioral health support into crisis centers and residential substance use and inpatient centers. For example, we have like OCARDA and Depression Bipolar Support Alliance and other 12-step groups that are coming in, and they're bringing groups in there so that folks have that other connection outside of the traditional behavioral health to have a link to for when they leave, that links into that extra support that they need, that's crucial whenever they're discharging from services. So thanks for letting me share.
Yes, no problem. And Raquel Brown is also cheering with you on a shout out to Ocarda. So thanks for mentioning them, Tony. And then Lindy, would you also like to share some thoughts from your work in Oklahoma?
Sure. OCO Nagata, Lindy Dakwado Jijalagi. My name is Lindy and I'm a citizen of the Cherokee Nation, and I'm happy to be here among all of these panelists. It's an honor to be able to speak with you all today. What we've been working on at the Southern Plains Tribal Health Board for most of 2020 is developing a Native American peer recovery support certification, because Native American communities are often disproportionately affected by substance abuse and addiction. We adapted the state curriculum, and the certification, it will be housed under the Oklahoma Drug and Alcohol Professional Counselor Association. And because there are 39 federally recognized tribes within their own distinct traditions, food stances, and spiritual practices, it's essential for professionals to understand how to provide culturally appropriate services to the Native American community. Thank you.
Awesome. Thank you, Lindy. And then Noah, would you like to share your thoughts about the work being done in Texas?
Absolutely. Thank you so much. And this is an absolute honor for this group to be presenting and to be a part of this group of leaders in Region 6. Something that we've really been working on, I think first and foremost, I'd like to mention the creation of our unit at the state level, having a unit that's dedicated to building peer and recovery services across the state of Texas is a huge accomplishment. And we started just over 2.5 years ago. It was February of 2019. Now we're a unit of 8 people that are directing, the way that the state can support the growth of these services. And so we've been really charged with coming up with a vision. Of course, we're going to do that in a way that encompasses peer support, ethics, and values. So we've gone out to our stakeholders, held focus groups, elicited as much feedback as we can gather, and then included our own experiences building programs across the state. And the thing that is like the resounding thing that we're seeing is that we need to invest in, we need to build, and we need to develop community-based peer organizations, that we really see that as being the future, that being the thing that can answer so many of these challenges that we face. And I know we'll talk about challenges coming up, but something that we heard from our organizations around the state was that, they've been receiving ample technical assistance around how to deliver peer support and recovery services. And the reality is a lot of these folks, they're national experts that are providing technical assistance around the country. And that isn't necessarily the kind of support that they needed. But what they did not receive and what they were asking for was more business side of the house support, how to executive coaching, how to diversify funding streams, how to, succession planning. I think these are things, how to report on grants. And so what we've been able to do is locate what's called a Leadership Fellows Academy, which is a partnership between the University of North Carolina and in Greensboro and North Carolina State. And this is also through a partnership we have here with the Hogg Foundation, and then also the University of Texas Institute of Excellence in Mental Health. And so we've been able to bring this group and curriculum to Texas to focus on 17 community-based peer and recovery organizations. Those are recovery community organizations on the substance use side, consumer-operated service providers on the mental health side, as well as our mental health clubhouses, to come together and receive that coaching and the curriculum that's focusing on these business elements. And I think the Trojan horse there is that we can bring this community together and have all of us begin to work together a little bit more. I think each one of these different types of organizations has expertise and different strengths, and there's places that we'll be able to partner and support one another as we grow recovery around the state of Texas.
Perfect. Thank you so much. And just thank you to all of you for the work that you're doing. I see so many very positive comments from the attendees in the chat box, just acknowledging the work that you're doing and the impact that you're making. So thank you for that. And then I also just want to encourage the attendees, if you have any questions at all for our panelists, please feel free to add that in the Q&A box so that we can share that with the panelists. And I actually thank you, Donna, right on track there, Donna Fagan. So just a question for all of you all. It just, Rochelle mentioned support for families, family peer support. And so a question for you is, for all of you, is whether your states have anything similar or any programs moving towards supporting families with peer support. And I'll just leave that open to anyone who'd like to answer.
Well, I'm happy to get started with that. In Texas, we have a history with providing family peer support in the mental health settings to families of individuals under 18. We call them certified family partners, and there's a long history of, we have a certification and a curriculum, and there's measures in our performance contract with our local mental health authorities. So those are the providers of the public behavioral health service or mental health services, that they need to meet a certain threshold of those families must meet with family partners. So that's a way that we're trying to, make sure that those services are being delivered across the state. I'm excited to say that we've inherited a new position, a wonderful family partner by the name of Felicia Mason Edwards on our team, who's the subject matter expert at building family peer services across the state. Something we want to look at is how do we, I think we're right now in negotiations and talks about how to create a curriculum and begin to insert these services into our substance use settings, but we want to look beyond that. We're very interested in looking at how to expand family peer support services to family members of folks over 18. What we know is that the day somebody turns 18, these problems don't just go away. And the family supporting individuals that are struggling, they don't stop caring about us, And so we want to look at how we can get family partner services or family peer support services to adults. And I think we can look to the first episode psychosis programs as a model of how to do that. I know that family peer support is a part of that model, and that serves individuals older. The other place we're looking is at our ACT teams as a place where we can have family partner services. I think the other exciting thing that's really being pushed is how do we get family partners into other service systems? And I think what we know is that providing support to these families has much more to do with navigating complex service systems. And so we're excited to begin to explore that as well.
Militia.
Can I just piggyback off of Noah? So New Mexico also has a family peer support worker program. And it's pretty stellar. And what happens with the family peer support worker is that they support the parents and other primary caregivers to ensure that their voices are heard. And there is a youth peer support program. We all, what we're doing is trying to keep it cross agency so that we can help one another. And but it's much needed. It's like it goes hand in hand with the adult peer support worker, I think. And so we're here to support New Mexico with the youth having their own endorsement, and the family peer support workers also.
Tony, did you have a additional comment on that?
Yeah, we
And then I'll just kick it to Ricardo.
Oh, yeah, we too here have we in partnership with our Department of Human Services, we have what we some of our providers have we call them parent partners here, and they receive our core peer certifications, one of the requirement, but also a requirement to get those positions at those particular providers that are contracted to do that is they have to have that lived experience of having gone through like a DHS case, and what they do is they use that experience to support parents and families that are going through that and working to get reunited and help them process that and support them through the process. So
Thank you. And then Ricardo, Louisiana.
Okay, so in Louisiana, we have a coordinated system of care. And so within that system, we have parent support and youth support. And so those individuals work with the treatment team to improve the life or the well-being of the child. So the child is the primary focus. And so both the parent and youth support work along with the team, but also with the parents and youth to improve that child's well-being.
Great. Thank you. And then Noah, could you give us some additional information on the Leadership Fellows Academy? Is it open to peer specialists? And then kind of how would someone connect with the Fellows Academy?
So the Leadership Fellows Academy is, that's really an organizational focus. So we've invited, it's 17 organizations, and those are organizations that are currently contracting with the state in some kind of a way. And so it's more focused on the organizational level. We do have separate initiatives that we're right now in the place of propping up that would be focused at individual leadership. Like I think that's another thing that we're looking at is how do we build and grow like the peer support workforce and create more leadership opportunities. But the Leadership Fellows Academy is an organizational thing. So it's focused at organizations. Our hope is that our next iterations will be looking at how to grow and seed new organizations. But we wanted to start by working with our current organizations and what we kind of call solidifying our foundation, and they'll be acting as mentors in the future. But there will be opportunities for individual peer specialists to get leadership, receive leadership curriculums, but the LFA is focused at organizations.
Okay, thank you. And then there was another question. It was posed towards Texas, but I'm going to ask of all the states. And that question is there any system in place that involves peers partnering with the criminal justice system, particularly at the policing level? So Noah, it was cued towards you. So if you have any thoughts on that, I certainly allow you to answer first. And then for any other states that have peers working with criminal justice system.
I mean, our justice involved programs have been focusing, I think, more at like folks exiting the justice involved system. We've been doing re-entry pilots at 3 different sites in Texas that's funded through a rider a couple years ago. And we're talking now about creating a standalone certification for individuals, like a justice involved certification. I think, you know, at the policing level, I know I'd be excited to hear about what Arkansas has to say. We've been more focused at kind of creating re-entry curriculums. I know our it's TDCJ. I don't like the acronym's not like the wording of it isn't coming off my head right now. It's a bit late in the day. But our justice department that runs the jails is beginning a couple pilots to certify individuals that are currently incarcerated so that they're able to provide peer support to one another, and they'll be able to have a credential when they come out of the system. Yeah, that's what Texas is doing right now.
Thank you. Any other states? Jimmy, I see you came off mute.
Yeah, absolutely. So Arkansas we quickly learned, like Noah, we didn't really dive heavy off into just a statewide peer initiative in different pilot projects in different areas until late 2017. But we quickly learned that peer recovery was at its strongest when dealing with a community of incarcerated people, right? Like, so what we did was under STR, I was given a small amount of money to launch a small pilot project, basically covering one salary for one peer recovery support specialist in one community jail. Now, we isolated a pod so that this pod was separated from the other inmate population so that they could just get hope poured into them and not go back into a toxic environment after the peer support worker went home for the day. And so this pod quickly started bleeding off into the other geographic locations of the jail. Even the people that weren't allowed into the recovery housing unit, the hope that was beaming from the incarcerated people in the peer program started reciprocating all over the jail. And so what we saw a year later is out of the 16 men that were selected to be in that program, 12 of them a year after leaving the jail were employed, family reunification had taken place. They went from being burdens on the community to contributions in the same society they once destroyed. And so at $56 a day to house an inmate, now these were not just people, they had a history as extensive as mine. Like they had a timeline that within 4 to 6 weeks, they would recidivate or reoffend or be rearrested. And so had they stayed true to that timeline based on data from the last 3 or 4 years, it would have cost that county jail $276,000. So one peer support salary at $35,000 a year saved that jail and that community and taxpayers' money over $250,000. And so with that data, we quickly amplified the program. And so needless to say, now at this point, we are in 6 or 7 different jails throughout our state. We're in reentry centers across the state. We've got the overdose response teams that I talked about in the beginning, where the police and the peer are a partner. And so as the police is investigating the overdose crime, the peer is there as a voice for recovery saying, hey, listen, jail is not what this guy needs. He's willing to seek help. He is self-determined to live a better life. Let me help him do that. And so we're just seeing success at every level with criminal justice. We do have them in the drug courts. We are working on shifting the perception of the decision makers in the prison systems. Ultimately, I would envision that we have peer workers that are currently incarcerated working as peers. That's my next big thing. So
I can't wait to say this. Thank you, Lieutenant. I want to say too, when Jimmy starts talking about the law enforcement and peers together, it just gets me like all happy, because also before I was able to sit as a program manager for New Mexico, I'm a trainer, right? I am a trainer, and I was able to go in before I accepted this job into our Department of Corrections in Las Lunas, New Mexico, and train a group of 10 men with a co-partner, with a co-trainer. And we do have peers in there. They may not be working, but they are certified peer support specialists in our prison system right now. Some of those men will be able to leave the incarceration, but some won't. But some of the stories that we heard after they got their certification was that when they get when they, I'm sorry, I wear my heart on my sleeve, but when they get to walk a fellow peer that can leave that Department of Corrections with and equip them with the hope that they too can come out to society and hopefully down the road take a peer class and be a peer, that they've done their job, right? They, you know, and these are men that probably won't, 3 or 4 of them won't be able to leave, you know, the incarceration, but they get to do the work inside, and they get to take our CEUs, and they get to recertify, and they get to do all that. And the next project down the road is the women, you know, 10 more women in another prison. We, you know, you give a peer an idea, especially a peer leader, you know, we want to do things. We want to like make change. And I think that also with us having more collaboration with courts, peers are crucial. There was a judge that had a peer support worker in New Mexico that said to all his other fellow judges, it is vital, it is crucial that you have peer support workers in your courtrooms, because the success of reentry or recidivism, it goes down. It goes down. Because why? Because we've been there.
Thank you, and thank you for all those comments. Lots of positive feedback again in the chat box. For all the attendees who may be posting resources and links, please just be sure that you're using the option for all panelists and attendees. Otherwise, it just goes to the panelists and we're the only ones who get to benefit from that. So just want to encourage you to make sure you're using the option that includes attendees. So I just want to switch now to acknowledge a bit of a reality check that we know is not always sunshine and rainbows, but that in the work that you do, you certainly face your share of challenges and barriers to moving your work forward. And so I'd like if you would just take some time to share what some of those barriers or challenges might be that you faced, either just specifically in your field or actually within your state or tribe in the work that you're doing. And so Noah, you were the last one to go on the first question. So I would offer to you to be the first one to go on this question. Thank you.
Oh, thank you so much. I think, you know, something we've been talking a lot about right now in Texas and in our office is raising fidelity levels, raising expectations in general, whether that's you know, providing the support to the peer organizations and really upping their ability to meet expectations and provide services, or, you know, looking at how we can increase the fidelity of the trainers across the state that are providing the peer support certification training, increasing our supervisors' ability to provide the supervised work hours and feel empowered to you know, be able to, you know, help us select who is right for this work and who is not. And I think the same with, you know, the certification in general, that we really want when somebody has a peer support certification for that to really mean something, you know. And I think it's our role as a community to really raise the bar of excellence. I think what I've seen in every program that I've stepped into is the group of folks that needs to raise that bar are us as the peer specialists. And I think what I've seen before is, you know, sometimes it can get cloudy between what a volunteer peer support role is, which would be open to the entire universe. And we want everybody to have a million chances to get involved, and we want to engage with them and have that be separate from, you know, the profession of peer support, where you're going to be you know, delivering a billable service, being paid to do the work, having competencies and a code of ethics, that we want to have a high bar, a high level of a high expectation of excellence from individuals. And, you know, so that's really what I see as something really important that we're focusing on right now, and as a great challenge that we as a community and a workforce need to have that high expectation of service provision and excellence from one another. And I think through doing that, we can really take this thing to the moon, because truly the opportunity lays in front of us. Like it's there for the taking. If what had been going on in the past had been working, there'd be no need for our system to be transformed. But I think we're here to really take the reins and take things to that next level.
Awesome, thank you. And since we're going in backwards order, I'm going to transition now. Lindy, would you like to go next for Oklahoma? Any barriers or challenges that you would like to share?
Yes. So the Southern Plains Tribal Health Board funded the position of 3 peers working with tribes and tribal behavioral health departments. The position was brand new at all locations and relatively new for Indian country in Oklahoma. Our peers expressed struggles with supervision at work and support. The coworkers did not know what peer support would look like. The peers were new to the position and tasked with building their programs. So we saw a need for connection and support from other peers working in Indian country, and it seems this was needed outside of Oklahoma as well. Peers mentioned about cultural isolation they've experienced at work and the division between them and other mental health and behavioral health providers. So we partnered with the Northwest Portland Area Indian Health Board to join the Indian Country ECHO Collective with a peer support ECHO. An ECHO is an interactive virtual classroom. But if you want to learn more about Project ECHO, there is a flyer available for download on the conference website. And I forgot to mention earlier that there is a download for the Native American Peer Certification Information Booklet on the website, as well as a Native American Peer Recovery Support Toolkit developed by Southern Plains Tribal Health Board. But so it was anticipated that the stress and social isolation caused by COVID-19 would have an impact on those who struggled with drugs and those in recovery, and it did. We wanted to offer support to the peers who were working with clients and on the front line seeing this impact. So because of this, we started the ECHO much earlier than anticipated in April 2020. But because the ECHO was developed for Indian country by Indian country, culture is naturally integrated at every level. Both faculty and the participants share their professional and lived experience. The didactic presentations integrate Indigenous knowledge into the dominant culture paradigm, and case studies address the unique needs of recovery process for Native Americans. It's really developed into a trusted space where peers can share their cultures and traditions, speak their language, and engage in storytelling.
Thank you for sharing that. And then also for Oklahoma, Tony, did you have any challenges or barriers that you might want to share?
Yeah, I just wanted to say I've gotten to participate in one of Lindy's, the Echoes, and they're awesome. So doing an awesome job with that. But some of the, right now, what we're facing, one of the biggest challenges we're facing is like peers. It's a good thing, and also it's a challenge because like it's blowing up in Oklahoma, peer support. Right now we have 900 active certified peers, and then the applications that are coming in, like we can't meet the demand. So what we're trying to do is figure out how to meet this demand of folks wanting to become certified and providers hiring peer supports, and also kind of like going with what Noah was saying is and uphold that fidelity of the certification. Right now we require for those that are certified or contracted through the Department of Mental Health in order to supervise a peer, you have to attend our supervising peer recovery support specialist training that we provide through the Department of Mental Health and Substance Abuse Services here in Oklahoma. But is that enough? Is that enough? Do we need to maybe have where those supervisors are required to get continuing education units? That's something I've been thinking about, just to make sure that we're holding that fidelity that peers are being used what they're meant to be used for, and not in other, kind of what was mentioned, in the presentation earlier today, making sure they're not using in like a clinical role too much, or they're not like assistant case managers or administrative assistants, because that's not the role of a peer recovery support specialist. So that's what we're working on now, and trying to do our best to make sure we're meeting that demand and training as many folks as we can, but also making sure that they're being supervised appropriately.
Great, thank you. And then so we'll move and transition to the state of New Mexico. And so Rochelle, did you have any barriers or challenges that you faced in doing your work that you may want to share?
So some of the challenges and barriers for me, or for us recently, is that, besides all the alcoholism, there has been a lot of methamphetamine use in the Gallup area, and that makes our job a little more difficult because, they're not fully here, their brain's not clear. And I forgot to mention earlier that we were also working with the high utilizers in the emergency department with the Gallup Indian Medical Center. And what we're trying to do is get these guys out from being in the emergency department so much, because some of these, they're no longer staying in hotels anymore. COVID-19 is still around. So that, I think, is one of our challenges right now, is just trying to continue to get them off of the streets. And being a peer and recovery, we know that we can't sober up these people. They're not ready. But what we can do is carry the message and plant the seed, and I've learned that the hard way is you plant the seed, it's their choice whether to water it or they let it die. And I took that to heart a lot, because I'm one of those that likes to go out there and say, hey, are you ready for this? Or I tell them my story, or, some of them will come up and say, how did you do it? And that's the opportunity to say, well, this is how I did it. And I'm one who recovered in Alcoholics Anonymous. I have done the 12 steps. So that is another challenge, is this trying to share that with someone else, to share it with the individual who is under methamphetamine and alcoholism and who knows what else. So right now we're trying to work with the Gallup Indian Medical Center to get these guys into treatment centers like the Four Corners Detox Recovery Center. And with them, it's a very great place to go. They're very helpful. They're very loving. They have gotten plenty of people off from the streets in New Mexico to the recovery center in Santa Fe, and that's very heart touching. One thing that had happened was the Wellsprings Treatment Center had closed down in New Mexico. So a lot of them had to come out and find help all over again. So that was one of our challenges now. Thank you.
Thank you. And so Militia will transition to you.
Thank you. Yeah, Rochelle, I'm glad that you touched on that, because a big treatment facility in Gallup did shut down. And so now the Santa Fe Recovery Center has helped take over that. And also, can I just say that our RCOs, and Noah talked about this earlier, our wellness centers, our drop-in centers, the amount of open times that they had during this pandemic, it went down. So the folks that were used to coming in, that was a challenge. The office hours changed. One of our wellness centers, called the Hojo Center in Gallup, it actually had to move. It moved from one place to the other. And so there was a lot of people on the street that were confused, didn't know it was shut down. There were normally, they would congregate at the old Hojo. And so that was challenging. And also what Noah touched on was the same for New Mexico, holding the fidelity of your certification as a certified peer support worker. It's huge. It is so huge. And yes, I understand, that the application process, we're going through the same thing. The demand is high because providers now we're a billable service. We are a billable service, but the bar, we want the bar so that peers, when they take this training, they know the code of ethics is real. It is real. And when you come to a point in your life where you are ready to start helping other people, and you have that in you, we're professionals. There's a term that they use about peers, and it's called paraprofessionals. I don't believe that we are paraprofessional nothing. I believe that we are professionals and that we should be treated that way, but we also need to be the example for other peers out there, so that they cherish that certification. And we also we want to, in New Mexico, July 1st, not want to, it's coming to fruition. As we increase all these applications and these trainings, as we increase the professionalism and the eligibility expectations for our credentialing process, we are moving that up to a 3-year mark. It was normally in the past 2 years, July 1st, 2021, we are moving that up because we have a lot of peers applying, and we want to hold that bar high, but we also want to learn about other states on this call. And we're going to take their guidance on the supervision, because we want those peers that that want to supervise, that know how to supervise, and keep it non-clinical. But actually, I'm just going to say, and I'll be transparent, I'm supervisable, and my supervisor is a clinician, but I'm supervisable, and I got to get humble that way. We are going to be supervised at one point in our lives by clinicians. And so the fact that I'm okay, that I've grown, I think that more peers in the state also will fit that criteria. We would want to be good examples. But that's one of the challenges that we face, is that we don't have enough peer supervisors at agencies. So we're working on it.
Thank you. And before I turn it over to Jimmy, there was a question that came up for both Rochelle and Militia. And just briefly, if you might have an estimate, a roundabout number about how many clients do you feel you all are seeing and serving on a monthly basis? Just if you have a number, you might know.
I'll let Rochelle, since she's out there in the field working as a peer right now, I'll let her. Yeah.
Oh, hi. So it varies on our clients. Sometimes, it goes down to 3 or 4. Sometimes we have 7. For our supervisor at LLTI, she doesn't want us to have a huge caseload. And she's very mindful of self-care. So she gives us a limit, let me know how much you can handle. So some will have 7 to 9, some of us will have 3 to 4. So it varies.
Okay. Thank you. All right. And then Jimmy, can you wrap it up for us on what barriers or challenges you feel you faced in your field and the work that you're doing in Arkansas?
Absolutely. Thank you, Lieutenant. So, the current challenges I see at my level in the game is that often decision-making positions try to decide the future of peer support without including the peer support workers in that conversation. And so a prime example of that is a notice of funding opportunity may go out, and the scope of work that they put in this grant position doesn't fit peer at all, because they didn't think to stop and go talk to the subject matter experts surrounding the field of peer, which is one of the pillars about us. Nothing about us without us. You know, if you want to learn about underwater basket weaving, then you need to go talk to somebody who's a pro at underwater basket weaving, right? Like, don't just decide that you are going to implement the rules and regulations and policies and procedures around something that we live and die for without talking to us, because you'll dilute the pool of peers. And so one of those things that we faced early on were people confused about the role of peer support, not just from the clinical side, but the recovery community. I remember having a hair pulling out match, which is why I don't have any now, with someone who was in long-term recovery for 22 years trying to tell me, I've been a peer for 20 years. No, you have not. You've been a recovering person for 20 years. What makes you a peer is your code of ethics, your training, your ongoing education, the professionalism of the field. What qualifies us for the role of a peer is our lived experience, like Dr. Deegan was talking about earlier. And so something I keep hearing, which is going to be a common challenge for peers everywhere, is supervision. Arkansas does not have clinical supervision at all for our peers. What we quickly saw was the burnout session that peers would experience at $12 or $13 an hour without having a career ladder. So we developed a career ladder. The Arkansas model is a core level peer, and then you have the option to go and become an advanced peer worker and then a peer supervisor. And so each one of these levels require 500 hours of on-the-job service experience that can only be signed off on a peer recovery peer supervisor who went through the previous trainings. So, and we didn't conform to Medicaid. What we did was we took the grant money from STR and we built so much data supporting the need and the success rate of peer support that if you don't have one, you look foolish. And so anywhere you've got mental health diagnosis and addiction, you should also have peer recovery support specialists, because people in recovery are the strongest tool that we've got to combat the stigma of addiction and mental health. And we are the hope that other people need to want to self-determine to try this way of life, that they can and that they will if they choose to. And so we did create that career ladder, and there was a lot of pushback from the clinical side, people not understanding. But here it is, Lieutenant, in the simple gist of it is, if I want to be a doctor, I don't go to a mechanic to learn how to do doctor work, because they use a wrench and not a scaffold. That's all.
Well, I don't know about y'all, but are we ready for the A and B selection to pass the offering plate? I feel like we just had a little bit of like some church and some honest sermon speaking right now. So thank you to everybody for your honesty there. And I've learned so much from you. And so I do want to end kind of on some high notes, some positive notes, in thinking about the future of peer services and what you're most hopeful for, either in your state or overall for peer services. And so I actually would like to start. There is a question right when we opened up this session from Patrick, and I was holding on to this question, and this is very much future thinking. And it's just about, what advice, if any, would you recommend to the next generation of leaders who are stepping into their roles of leadership as peer support specialists? So couldn't be more future forward than thinking about, what are your recommendations for the next generation? And that's for anybody.
Be teachable. Be teachable, because it wasn't that long ago, Lieutenant, that we were doing lobotomies. So peer is ever evolving. What some states may consider best practices, another state may come along next year and combat that with data that says that's really not the most effective way to do things.
I'll say, do not take anything personal, especially when you're moving up to a leadership role. Just don't do that, or try not to. I mean, we care, we think with our hearts, peer support workers. And not with our minds sometimes. I just, not to give advice, but a suggestion is just don't take, and don't take yourself so serious. I think that the voices, having a voice at a table where there are big leaders with those letters behind their names, it could be intimidating. It was for me. But, once we say the truth and our suggestions are real and they come from a good place, a place where we can make decisions for peers, about peers, just like Jimmy said, then we have nothing to be embarrassed about. But we don't have to be perfect. We're human.
Thank you. Tony.
My advice is like learn, be humble, be willing to stretch your comfort zone a little bit, put yourself out there in some spaces that you may not be comfortable with. And, just be yourself and know that you're worthy. I think like sometimes I think we don't put ourselves out there because we don't feel like we're worthy of moving into that role or being in that leadership position. You are. I promise you are. So just know that.
Yeah, something we run a pilot in Texas several years ago that was it started youth recovery communities, which was providing recovery support services to young people. And the program specialist that oversees that project, Suzanne Alley, she always talks about how the generation before us, like the younger folks, they don't even see that distinction all the time between mental health and substance use. Like it's so, like everything's so brought together. And something that I would talk about is, like push us. I think, like what I did when I was emerging, the amount of passion that I had, and there were opportunities for me to push things forward. And I think not only is the advice to new emerging leaders to push us and to bring that passion and to not take the status quo as the way it needs to be, but also a challenge to all of us to make room and space for that, which means stepping aside sometimes, trying to look for those new faces and new leaders. And that's something I know our group is always talking about, is how can we grow and foster that next generation. But I would just invite our new leaders to push and make things uncomfortable. And we really need to take that on and be able to take that information and be open to being uncomfortable.
Thank you. I did want to ask for all of our panelists, there have been so many comments just asking for who should our attendees reach out to in your state, contact information if available, or website to go to, not just for the CPRSS, but also just connecting with peer services. So we have about 15 minutes left in our panel discussion. So if that gives you a bit of time to post that for all panelists and attendees, I believe it would be very well received and appreciated from our attendees. So again, if you have any point of contact information for the CPRSS in your state, or a point of contact for connecting with peer services. So thank you there. And then again, so just leaving the discussion open, thank you for answering that question. And another question really is about just what's next for peer services? What's next for your field? Where do you see the future for your field?
I think, we get phone calls at this point, Lieutenant. We are visiting states with the country opening back up. We get calls all the time about our supervision model, and our drug czar and myself are scheduled to visit several states in the near future, starting in September, actually, on how to develop and design their own implementation. And we're also getting calls from RSS divisions from all over. And I think what we're going to see at a national level is peers being supervised by peers. I think that's coming. I think policy makers are being influenced, and they're seeing the value and the common sense in in that, and I think we can expect to see more of that.
Thank you. Any
Um,
other thoughts, Lindy?
Yeah, the future of tribal peer support in Oklahoma is bright with some sustainable funding. The Oklahoma Healthcare Authority has passed legislation for OMB reimbursement for tribal PRSS services beginning in September of this year. And, you know, we really hope that that will be a way for tribes to really utilize the peer role more.
I think, like I had mentioned earlier, we really see the growth of these peer organizations as being the future. And I think, you know, that we don't have to worry about other folks defining supervision models or payment structures if these independent peer-run organizations are able to do what we know they can do. And I think if you think of what that means, if people and services are immediately connected to the community, because what we know is that, you know, we can get the tools and the skills and the opportunity for recovery inside of a treatment setting, but recovery happens in the community. And so having that immediate connection for somebody to the community, and then you sort of think of like, if this is a place where you can get trained to become a peer specialist, and then those organizations are connected back to our clinical and treatment organizations, it can become a self-feeding ecosystem. The other thing is, you know, we've seen like certifications created out the wazoo, but that doesn't create jobs, you know, and what we need to do is create more high-paying leadership jobs for people. And we see that also as the investment in these peer organizations. As they become more sophisticated, there's going to be more job opportunities. And as we see these different bills being filed for, you know, the ones in Texas this session around youth peer support, around peer support in the IDD system, peer support for like perinatal or peer support for new mothers, peer support for law enforcement, you know, like these things are not going to stop. And I think it's going to be key to all of us to make sure that there's a linchpin and that we're united around what peer support is as these new emerging opportunities come together. And if our community can walk together, then we're going to see things explode, you know? And I think like Jimmy had said, like Tony, like all of us, like these opportunities are all over the place. And really it's the responsibility is ours as peer specialists to truly define this. Cause I think this is an emerging movement. And I think that, you know, we have everything it takes to take it to that next level.
Thank you. And thank you all for posting contact information and some links in the chat box. And if it's okay with the panelists, if the panel discussion, the organizers, the conference organizers could post your contact information on the website, if that would be okay with you.
Please
Thank
do.
you, and some of the additional links that are there. So that will be available. And then I just want to ask one final question that I saw pop up. And so this one is actually, could be considered maybe a bit of a challenge, but the question is really, how have you navigated balancing the core peer value of multiple pathways to recovery in workforce development when so many employers and some state certifications require abstinence in order to become certified? If anyone has any thoughts on that.
Yeah, I can tackle that one for sure. And I'll be short. So there's a difference in being a peer worker and being a peer receiving services. I am a national advocate. So if I'm expected to be at state capitol advocating for laws, I don't need to be the guy that was just smoking a blunt and knocking back margaritas last night, because I'm an image of recovery. Now, that does not mean that me as a peer worker who is abstinence-based cannot support someone whose pathway is medical marijuana. See, there's a difference in me being held to a higher standard as a service provider than the person receiving services. That's all.
I think, you know, I would say that we don't use abstinence as the bar in Texas. I think what we talk about is somebody needs to be in a solid place of recovery. And that recovery means that, you know, these obstacles in your life are no longer obstacles to you being able to do the things that you want in your life. And I think we want to be this is some of the advice and guidance we're giving is we want to stay from a supervision standpoint, from a certification standpoint, we want to stay away from policing or assessing someone else's recovery. We want to stay focused on performance. And that performance and those ethics that we have, you need to be in a solid place with your recovery. You can never be delivering a peer support service while under the influence of any substance. That's on our ethics, the same as other professions. But we want to be very careful that we're not creating a second class employee with peer specialists, holding peer specialists to a standard that other professionals are not. And the other thing around requiring, you know, what that means if somebody were to have some kind of a reoccurrence, and that it's really like your recovery is your responsibility. And we need to provide people with ample opportunities, but we also need to have high expectations of performance. And we can see in lots of other clinical professions what those standards look like, a path to getting back. But I think we need to be very careful. I think, you know, getting what ADA laws are, you know, and getting into somebody's personal health information or perceived or real disability that they may have. It's just things that we need to be very careful about. So I think as long in Texas, we stay focused around, you know, what are the performance expectations and what's the code of ethics? And if we're focusing there, you know, and somebody is behaving in a way, whatever that is, including a use of a substance or something else is making them be in a place where they're unable to perform those duties, then that performance is the issue, you know, and that's something that's very tangible.
And then, Militia, I believe were you wanting to add on to anything, or did I mistakenly see?
It's the same in New Mexico. I mean, meeting the criteria, it does state, you know, have demonstrable recovery from, you know, the 3-year, you know, showing demonstrable recovery. If you're working as a peer support worker, they have, you know, at an agency, they've got an internal, they have internal rules there. And I know for me, when I didn't show up to work, you know, there was something wrong, you know. So if they can see what that is internally and you know, and handle it internally. But if a complaint comes to us and that we have to send to the board makes a decision. Their recovery is none of my business. But if it's out there and it's, you know, and it's hurting, do no harm is in our ethics, and it's hurting your performance and your, you know, and the peer that you're serving or helping save his life, then, you know, then it's probably a no, and you know it too. I know it's not be true. You know, that's the way I see it.
Thank you. Thank you all for answering all of our Q&A from the audience. Thank you for such a thoughtful, insightful discussion about the work that you're doing. As I mentioned earlier, I've certainly learned a lot. I believe our attendees have learned so much just based off of the comments in the chat. So just thank you. And I just want to acknowledge all the hard work that you're doing and how you are making a difference in your peers and the future generations with the work that you've been doing so far, and the challenges that you acknowledge, and just your optimism for what's coming next.